Utilization management critical success factors. Top techniques for increasing the impact of a utilization management program. I'm Brian Jackson. I'm the Vice President and Chief Medical Informatics Officer at P Laboratories, as well as Associate Professor of Pathology at the University of Utah. For most of the last 2 decades, AACC has been working with our laboratory clients to set up and run and support utilization management programs for diagnostic testing. One thing we've noticed is that while a number of our clients have been highly successful at setting up such programs, some have struggled. Our rough estimate at the moment is that about 1/3 of our clients have some sort of a utilization management program, and about half of those clients would be considered highly engaged in running the program. So why are some organizations more successful than others? The first thing to keep in mind is that utilization management of lab tests is not simply about any particular tool or piece of software, report, electronic medical record or EHR feature, policy, procedure, or really any time-limited program. It may involve all of these things, it may involve most of these things, and probably more. But it's really about having a comprehensive end-to-end program that solves the problem that, of improving test ordering, as opposed to any one isolated tool or program. So one analogy that's useful for thinking about utilization management, or really useful for thinking about any sort of management of clinical activities, is to use the analogy to the fire pyramid or the fire triangle. So as any firefighter will tell you, there are 3 elements to a fire, and if you take any one of these away, the fire goes away. It simply can't exist with only 1 or 2. And those 3 elements are heat, oxygen, and fuel. So the analogy in clinical management is that unless you have data, people, structures, and processes, and the appropriate interventions, you're not going to be successful at managing physicians' activities. So let me start with data. So data is analogous to the heat in a fire, partly because you really need data to get the system going, and partly because as your utilization management program grows, it generates additional data which reinforces and supports the program. So a few examples of the types of data that are useful in a UM program. What I'm showing on this slide is some analysis that we did for a large academic medical center a few years ago, looking at their vitamin D testing. There was a perception that there was excessive ordering of vitamin D, but it's hard to manage this unless you can drill down into the details and see where it's coming from and why. So the first step was looking at the total number of tests, and that there were 5,100 tests performed over a 1-year period of time on 3,300 patients. So the first thing you may notice is this is more than 1 test per patient, which is probably excessive. But then drilling down further, you see that 1/3 of these orders were for the vitamin D125 dihydroxy, which is very rarely indicated. And we're probably ordering errors when the doctors really just needed the 25-hydroxy for vitamin D screening. On 906 of these patients, the 2 tests were ordered in tandem. Another example of useful data analytics is looking at repeat intervals. So for thyroid stimulating hormone, for example, most clinical chemists are familiar that TSH doesn't change very quickly in the body, even when thyroid medication doses change or other biological changes occur. But from a biological standpoint alone, it doesn't really make sense to check a TSH again in less than about 4 to 6 weeks. So in an analysis that we did for a large multi-hospital system recently, looking at repeat intervals, we saw that out of about 25,000 test orders for TSH, about 11,000 of those were ordered in less than 30 days. And when we broke this out by individual hospital, we saw that the proportions were pretty constant across the different hospitals. Did the same analysis for lipid panels. So this is a test that most adults need about once a year, but occasionally if you have a change in therapy, it might make sense to repeat in about a month. But we found that about 40% of the lipid panel orders at this hospital system were repeats less than 30 days from the previous lipid panel. And again, breaking this out by hospital, we saw a pretty consistent pattern. Third example we looked at was hemoglobin A1C for diabetes, which is typically needed anywhere from quarterly to annually. But we found that in the system, over a third of the orders were repeated in less than 30 days. And again, although there's a little bit more variability here, not a lot of variability across the different hospitals in the system. At AACC, ARUP announced and launched our online utilization management dashboards for our laboratory clients, whereby our clients can monitor their overall health system ordering trends, monitor commonly misused test ordering patterns by drilling down to individual test categories, and importantly, monitor physician ordering patterns by drilling down to the individual ordering physicians. Okay, the second element of the fire triangle after heat is oxygen, and the second element of the clinical management triangle after data would be people structures. So it's really critical if you want any sort of a clinical management program to have the executive leadership of the hospital or the health system on board alongside key clinician leaders and key IT leadership and frankly IT frontline staffing as well. For lab utilization management, we strongly recommend that these programs be clinically driven and pathology supported. So the nominal leadership of these programs is typically a internal medicine or a chief medical officer or usually some sort of a non-pathology leadership individual, but strong support from the laboratory and from the pathology department are extremely important. One important thing to point out when we talk about getting clinicians on board for these programs, there's a common perception that the practicing clinicians are going to be resistant to any sort of efforts to manage their activities. And that's understandable. And some of this comes from the fact that a lot of utilization management historically was done by insurance companies who are very insensitive to frontline clinical needs and can really alienate and turn off the doctors that they're interacting with. On the bright side, though, there was a survey a little while ago from the Choosing Wisely group. So this is an initiative of the American Board of Internal Medicine Foundation, where they ask doctors questions about overuse of diagnostic tests and procedures. And in the survey, about half of doctors surveyed reported that their patients ask for an unnecessary test or procedure at least once a week. About half of them reported that they'll order something they consider unnecessary if the patient insists. And close to 3/4 of doctors reported that the frequency of unnecessary tests and procedures is a somewhat or very serious problem, and about the same proportion reported that they personally prescribe an unnecessary test or procedure at least once a week. So this shows that there's a lot of awareness and sensitivity to these problems on the part of clinicians, and suggests that it shouldn't be too difficult to engage them in a thoughtful program. Okay, the third element of the clinical management triangle after data and people is the individual interventions, the programs or the activities that provide the feedback, provide the analysis, and are actually sort of the substance of a utilization management program, in the same way that wood or paper is the substance of a fire. So step one is developing a formulary. The word formulary comes out of the pharmacy world, where it talks about the ways that different drugs are categorized by cost and use and specialty in order to manage the use of drugs more effectively. The analogy here on the laboratory side is to categorize laboratory tests in ways that are useful for the management. So one way is to categorize by cost and volume. So for example, there are low volume, high cost tests, particularly send-out tests, high-end genetic tests, oncology tests, genomics. Things like that are particularly amenable to expert review of ordering, management activities that might take a little bit more time and be a little bit more labor intensive, but they're worth it because of the costs of the tests. And they're not so, the time and labor involved is not usually a huge problem because these tests tend to have longer turnaround times anyway. At the other end of the spectrum are the high volume, low cost tests. So the more routine things, think CBCs, routine chemistry panels, etc. These are the sorts of tests that really demand a different management approach, more of a bulk aggregate approach that doesn't hold up the turnaround time and also doesn't impose a lot of additional labor costs on the tests. So categorizing by cost and volume is one important step. A second categorization that's extremely helpful is to categorize according to where tests are on the technology adoption scale. So emerging tests would be the newer technologies that don't have much, if any, clinical data, or I would say much, if any, clinical evidence base to support their use. These are tests that should be used very selectively, generally by subspecialists who are expert in that area. And one management activity is to make sure these tests are not used by non-experts, for example, and that the volumes are monitored and the discussions occur about review of the evidence and appropriateness with the appropriate experts. At the other end of the spectrum, we have late-stage obsolete tests, so tests like reverse T3 or total serum phospholipids or tests like that. In the more extreme cases, the appropriate intervention is to simply take these off the menu. But in some cases where there's a strong argument that they should stay on the menu, then they should at least be managed and monitored and feedback occurring to the doctors who are ordering them so that they could be pulled off the menu at the time when it's deemed appropriate. So in addition to categorizing tests in a formulary, other types of interventions include using suggested repeat intervals to provide feedback to doctors and reduce redundancy, as I referenced a few minutes ago. Expert review of high costs and high risk tests. Simplification of the EHR ordering menu. At our own academic medical center here at the University of Utah, we did an analysis that showed that half of the tests that were built into our electronic medical record ordering system had not been ordered at all in the previous 12 months. So those are obvious candidates for simplification. And 50% of the remaining tests had only been ordered once in the previous 12 months. Again, an opportunity to clean up the menu, pull things off that really don't need to be directly physician orderable and could be turned into miscellaneous tests, those sorts of things. Reflex ordering, mainly to reduce the shotgun approach of physicians wanting massive panels for things like neurologic disease and such. Price transparency can be an important component of these programs. Active management of order sets and preference lists. This is actually a key intervention because once a test is listed on an order set, it's much more likely to get unnecessarily ordered. So in conclusion, active management of physicians' test ordering patterns has a lot of potential, not only to reduce costs, but to improve the quality of care. And we at P Laboratories are committed to helping our clients to establish and run test utilization management programs to improve the care of our patients. And I thank you for your time.